Hello, my name is Amy Mikhail. I am a second-year internal medicine resident in UT Health Tyler, Christ's Good Shepherd Medical Center in Longview, Texas. I'm here today to present an interesting case of retroperitoneal fibrosis. Retroperitoneal fibrosis is a rare condition, identified in only 0.1 to 1.3 cases in 100,000 persons per year, and characterized by the presence of inflammation and fibrous tissue in the retroperitoneum that generally localized around the intrarenal portion of abdominal aorta and iliac arteries, often encasing the ureters or other abdominal organs. It was initially named Ormond's disease. It also had many other names like periuretritis fibrosa, periuretritis plastica, and fibrous retroperitonitis. Our case today is about an 86-year-old Caucasian male with a past medical history of chronic kidney disease stage 3A, hypertension, and hypothyroidism. He also has a past surgical history of fibrous chest wall mass excision, who presented to the emergency department with a complaint of generalized weakness, dull, non-localized lower back pain, and decreased urinary output for 1 week duration. His vitals on arrival were within normal limits except for a blood pressure of 167/76 and a pulse rate of 110. Physical examination was prominent for diffuse bilateral crackles, lower back diffuse tenderness to palpation, and an old surgical scar on his right chest wall. On arrival, his lab studies were notable for hyperkalemia at 6.4, elevated creatinine level at 9.26, and blood urea nitrogen at 99. His last known creatinine baseline was 1.4. CT abdomen image revealed retroperitoneal fibrosis with resultant right uretropelvic junction obstruction and hydronephrosis. He received appropriate treatment for his hyperkalemia. Then he was taken to the OR for cystoscopy and placement of a right urethral stent. Afterward, he was placed on continuous IV maintenance fluids. Over the course of the next 3 days, his initial symptoms resolved, and his creatinine level returned to near baseline. The classic retroperitoneal presentation of a non-localized back pain, decreased urine output, acute kidney injury reflects obstructive uropathy. After prompt relief of the obstruction, classification of the retroperitoneal fibrosis as primary versus secondary is required to guide the management. Primary retroperitoneal fibrosis is responsible for approximately 70% of cases and can be further divided into IgG4 or non-IgG4 related. In either cases, glucocorticoids are the first line of treatment. In secondary retroperitoneal fibrosis, treatment starts with discontinuation of the causative drugs or agents and correcting the underlying etiology. Glucocorticoids are generally reserved for refractory secondary retroperitoneal fibrosis cases. Finally, retroperitoneal fibrosis is an uncommon cause of obstructive uropathy. Untreated patients may develop severe complications or even progress to end-stage renal disease. The goal of therapy are to relieve the obstruction, stop progression of the fibrotic process, and prevent recurrence. That will conclude our presentation for today. I hope that you enjoyed it. I want to thank all of you for your time and attention, and I hope you all have a wonderful day. Thank you.